Now I'm going on. Okay. Yeah, I'm ready. Okay. Welcome, everyone. As folks are coming in from the waiting room, we're happy to see you all. My name is Margie Beaudry. On behalf of Trust for America's Health, I'm very pleased to welcome you to today's Huddle call to discuss challenges and solutions for ensuring access to COVID-19 vaccines for older adults and people with disabilities who cannot leave their homes. Please mute your lines unless you are speaking. This session is being recorded so that we can capture all the ideas and experiences shared. This call series is part of an initiative to identify and foster adoption of innovative and promising practices on this topic. This work is made possible through the generous support of the John A. Hartford Foundation and the Cambia Health Foundation, both of which are dedicated to improving health for all. TIFA has been leading efforts for the last few months to explore the challenges of ensuring that older adults and people with disabilities have access to the COVID-19 vaccines. We have learned a lot and have heard from so many people, like those of you on the call today, that there are solutions and challenges to get the vaccines to these populations. As we learn about the challenges, such as defining the term homebound, finding these individuals, expanding the pool of vaccinators, and ensuring full reimbursement, we have also identified some policy recommendations that will soon be published and disseminated to help inform and guide policy leaders across the country. We are very pleased that there is growing attention among the media and federal agencies, including the VA, CDC, and ACL, as well as national stakeholders. But there are still a lot of complexities, and there is no single strategy for ensuring the vaccines get to those who are homebound. Today, we do not have a speaker, but want to share with you some of the recommendations for your feedback and discussion. In studying this topic, we are seeing some themes emerge, such as increasing the vaccine supply, ensuring access for caregivers, vaccine hesitancy, and identifying those in need. Normally on these calls, we would have an expert speaker, but today we want to share with you some of the recommendations and have a discussion, hear your feedback. So with that in mind, I'm going to take a look at one of our recommendations. And the way this will work is I'll read you the recommendation. You can see there's some questions on the page, and we can go ahead and have discussion. Feel free to put your hand up in the chat. Put your hand up in Zoom, or you can put a message in the chat. So define the population. The recommendation is develop a standardized operational definition of people who are homebound that can be used to prioritize and provide COVID-19 vaccinations for this population and their paid and unpaid caregivers. Floor is open.
So Margie, if I could just hop on here and just let folks know that, this is really an opportunity to share what you're learning, to share what your challenges are, for us to kind of, hear from you. Is this the right language? What do you think about this approach? And then the first question that Margie has included here on the slide is, what definition does your jurisdiction use? Are you even aware that there is a definition within your jurisdiction? So we're really curious about where your states and local health departments are, or your jurisdiction. So please feel free to share.
And Serena Chow has a comment in the chat. Serena, do you want to unmute and just talk to us directly, or shall I read it for you? What do you prefer?
Oh, sure. Hey, everybody. So yeah, I just took this from the mass.gov website. Let's see if I can even see it. So I know you remember Robin Lipson gave us the talk a few weeks back about the homebound program, vaccination program that Massachusetts has set up, that either the local Board of Health is going to give vaccines or a basic centralized vendor who's going to manage the other folks. And so in order to qualify for it, we've defined in Massachusetts homeboundedness as being unable to leave the home to get to a vaccination site, even with assistance. And they have to meet one of the following three criteria: either have considerable difficulty and or require significant support to leave the home for medical appointments, require ambulance or two-person assist to leave the home, or are not able to leave the home for medical appointments under normal circumstances.
So Serena, that seems like it leaves a lot of room for, you know, just a lot of flexibility.
That's right. And I'm not sure how the central, if you remember, Robin said that there's a group at UMass that's doing the central intake. I'm not sure how they've been told to identify those situations, because it kind of reminds me of the CMS homeboundedness definition. It really leaves a lot up to the interpreter.
I wonder if others are aware where you are of what definitions, if any, are being actively utilized, if this has been a discussion, and what kinds of challenges you think will be faced if trying to establish a standardized definition across the country. And Serena mentioned the CMS definition. But it's clear that for COVID vaccines that that in different locations, different definitions have been used, or I guess that there haven't been such tight rules around it. Let's just say, put it that way.
And I'm also really curious as to whether, you know, would it pose challenges if there is, like the second question here, would it pose a challenge to Massachusetts if they were required to use the Seattle King County definition, or vice versa? You know, I mean, does it depend on, you know, the supply that you have available, the number of vaccinators that you have available? Because it seems like this Massachusetts definition could be quite broad, which could be great because you could cover a lot of the population. But then what, you know, what additional challenges might that pose?
Megan and Margie, if I can just add a thought, Megan, obviously not from a jurisdiction, I'm with the Johnny Hartford Foundation, but Serena, as you were talking, I think you said at one of the calls that this definition will result in about 25,000 people.
That's according to, I'm just quoting what Dr. Monica Burrell, who's our Secretary of Health and Human Services in Massachusetts, at a press conference when she was announcing this initiative, she said 25,000 folks approximately might meet this definition.
Yeah. I was just wondering, and this is just to throw out there, will the numbers present the challenge? Will they have to make the definition more strict if they don't have the resources to get, you know?
Yeah, that's interesting, because that number is actually lower than what I sort of tried to calculate on the back of the envelope. And so I wonder if the 25,000 is their guess as to how many people would meet that definition. But I don't know where I don't know the study or the data from which they determined 25,000 as the potential audience or the population that would be eligible. I don't know.
And I also wonder if it would pose a challenge based on where jurisdictions are obtaining their lists from. So, for example, if a AAA, an Area Agency on Aging, has a list of those that they deliver meals to, and you know, is that the same? You know, is that population then, or those recipients, those clients, the same as the ones that would fit the definition? I don't know. Just I think it, you know, it could pose additional complexities, but it also provides some guidance. So, love to hear from some of you.
So I think we can certainly come back to this. It's a piece of the puzzle that comes up a lot as we're talking about vaccine supply, and the distribution logistics is understanding the volume of people we're talking about, which emerges directly out of the definition, as you all were just discussing. But I think with that said, let's move on to our next recommendation for discussion. So this one relates to equity. So equitably vaccinate those who are homebound. The recommendation is guarantee equitable vaccine access to homebound persons and ensure that none are underserved or overlooked due to race, ethnicity, socioeconomic status, urban or rural location, or other factors. Obviously, this is a recommendation that is trying to be cognizant of both the history of health disparities and inequities in access to services of all kinds in the healthcare arena, but in particular recognizing that that there isn't an equal distribution of those who are homebound or those who are at risk for COVID, or who suffer the greatest risks related to COVID. So do you think that the current systems and processes that we have in place for distributing vaccines could undermine this goal, this aspiration? And if so, how is that?
Yeah, I'm just going to throw out an interesting report I saw on the Kaiser Family Foundation report this morning, and that has to do with rural areas. And it said that 1 in 5 rural residents has received a vaccination, but that 50% of those in rural areas do not want the vaccine. And I just, I understand that's based on, some politics, whatever, but I just, and that goes to the hesitancy. I know that goes to the hesitancy question as well. But, if we're looking at trying to make sure that we're covering all the rural areas, urban locations, and hesitancy is a barrier, right? Is becoming a barrier to getting that, people, not just homebound, but everyone vaccinated. So I just wanted to throw that out there as well as a potential barrier to achieving equity, is just hesitancy.
As you all are working on distribution of vaccines to those who are homebound, has this issue come up in discussion? What safeguards are you putting in place, or is this has this not really been on the radar?
All right, you folks are being shy today. We really do want to hear from you.
It must be Friday.
Hi, this is Maggie Ornstein. I just have a comment, and I think, something that we're seeing is that hesitancy is being conflated with lack of access, right? So some lower income communities of color are saying we don't even have access to this, and you're saying that we don't want it, and that's not true. So I think being careful and trying to figure that out. And I'm always asking about family caregivers and wonder if anyone is vaccinating family caregivers and if that's even an issue that we're talking about. And I think it's probably also based on what this, what we're just saying is that if there aren't enough vaccines, right, are we not including family caregivers because of the huge number potentially and not having enough vaccinations? So just something I've been thinking about.
Well, it's a fascinating angle on the equity piece.
I'll pipe up again. I didn't want to dominate the conversation, but so at Cambridge Health Alliance, I sit on our COVID vaccine task force of our healthcare institution, and we just happen to have a very community-based focus, and we have a whole group of people in our organization that are just advocates for community issues. And so I've been hearing that, at least in our neck of the woods, so we're in Cambridge, which is just west or north of Boston, and then we serve Somerville, Cambridge, and some communities north of Boston, some of which were really hard hit by COVID because of the nature of the people who live there. So Everett, Chelsea, Revere, which have a large proportion of folks who are Latinx, who are socioeconomically on the low end of the income scale, and there have been just lots of cases in those areas. And so what I'm hearing from different communities is that there are either both private and public entities that are taking the boots on the ground approach. So for example, the Cambridge Public Health Department, they've identified that there are certain pockets of Cambridge, which some areas are affluent, but there are some that where folks don't have access and they want vaccine, but they just can't get it. And so they've identified some low-income housing in a couple areas and are sending folks to those apartment buildings and knocking on doors. I think it includes the fire department as one of the people who are doing that, to get, to talk to people about getting the vaccine and signing them up ahead of time. And then I heard in some other communities, and I can't remember which ones, where they're setting up pop-up clinics using mobile vans that we've talked about previously on these calls, and just going to places that are central in those communities and advertising ahead of time. And hopefully their hope is that by doing so, by meeting them in their locations, that they'll have more success in getting people, or it'll be easier for those folks in those communities to get the vaccine.
So your comments, Serena, really seems to me go to infrastructure and the need to have in place ways to reach into communities that might not be well situated to be getting the vaccines right within their, within the walkable areas of their communities, for example.
And this is Jennifer Fuller from the Cambia Health Foundation. And I, just to kind of piggyback on that comment, I was actually on a call with some folks in Oregon last week, and they were talking about some of the work trying to get at, the issue around some of the hesitancy in the rural areas, and especially focusing on the older adult population. And that is exactly what we just heard. That was really a big part of their strategy, was just this, really the importance of finding sort of the champions in the community, and sort of who have that relationship and their trust is built, and doing a lot of just door-to-door conversing, mailers, much more old school, than like social media and the campaigns on the internet, just really, community, peer-to-peer conversation and connecting to try to build that trust, and in the process, get them the information of where they can get a vaccine and how to get there. And so I think my comment really kind of goes with the infrastructure piece as well. And then I think that the trust piece is a big part as well.
Thank you, Jennifer. And I also wanted to respond to Maggie's comment about caregivers and ensuring that the caregivers of the homebound have the vaccine. We've seen it really depends on what jurisdiction or who's delivering, who the vaccinators are. We've seen in some jurisdictions where maybe one local health department is more strict in following the eligibility guidelines, and then others are less so. But I think that now that so many states are going to be making everyone over 16 or 18 eligible, by April 19th is President Biden's, what is the goal, that I think, caregivers definitely should be covered. That's certainly part of our recommendation, is that all caregivers should be provided the vaccine when vaccinators are visiting the homebound. So I think that, we're seeing supplies increase, we're seeing eligibility open up. So I think that, caregivers definitely should be prioritized, and they have been in some jurisdictions. But up to now, it really has been very dependent on each jurisdiction's eligibility guidelines.
Thanks, Megan. One of the, thinking about family members, this is just, it highlights so much the way that they are ignored by the larger system just across the board. And so, opening up eligibility by age, certainly they're now eligible, but I think the larger issue, right, of how do we handle this moving forward?
Yes.
Thanks.
Yeah, I agree.
And
As a family caregiver, I wholeheartedly agree. Yeah.
Jane Carmody from John A. Hartford Foundation has put a link in the chat about an article. But Jane, would you like to just tell us briefly what this is about?
Well, I'm sorry for that long link. I'm not good at making shorter links. So that's the full link, and that'll take you into the Millbank. And what's the official name, Megan? It's Millbank Memorial.
Millbank Memorial Fund.
Yeah, and they just had, I would call it a blog, really about the work that's going on now. And I thought it was great. And I had just a side conversation with Jennifer at Cambia that had they seen it yet, because it just came out this morning that I had seen it. Maybe it came out yesterday. And I thought it was just great. Margie, it just kind of goes over well, Megan wrote it, so maybe she can tell about it.
John and I wrote it together. It's basically, we just wanted to highlight the issue, identify some of the complicating factors with getting to the homebound, kind of talk about what we've been doing, and then offer just some recommendations, kind of along the same lines as what we're talking about here today, just figuring out how to cover the costs, pointing to some of the great examples that we have, including Seattle King County Public Health Department, the Veterans Administration, pointing to the CDC guidance about getting the vaccine to the homebound. And then really 4 key steps that are in our recommendations: identifying the population, securing the vaccines, contracting with organizations that can provide home visits to administer them, and covering all the costs. So it's just a nice kind of overview. We feel like if you need a quick description of what this issue is and what some of the solutions are. So thanks for posting it.
Yeah, and Megan, what I liked about it is just, and that's what's kind of my note to Jennifer, was just kind of a work in progress. And I think it's wonderful because the full recommendations, as we're going through all of these and really be refining and discussing, will be in the policy brief, right, at the end of May or so. And so this is a wonderful way to share within your organizations some of this information. So
yeah, great, thank you.
Thank you, Meg.
So as we move into our next recommendation, the interesting linkage. So we've already heard about the issues of trust and the connection with health equity and the connection with vaccine hesitancy. And so this recommendation really touches on all of those things. Vaccinators reflecting the community. The recommendation is simply to ensure that to the greatest degree possible, in-home vaccination teams include people who are trusted by those being vaccinated and represent the diversity of the population being served. And some of the issues and questions this raises immediately is, well, it's a great idea. Is this realistic given what's available across the vaccinator pool? What do we do to make this happen? And what's happening in your community in this regard? Would love to hear your thoughts on any of those questions.
Serena, I'd like to put you on the spot again, just to ask if has this been an issue in Massachusetts? Well,
I think it gets to someone else's comment about trust and having people from the community at the front lines. It's not something that we've discussed either at Cambridge Health Alliance, nor have I heard in our state circles, but not to say it's not important. Mm-hmm. My sense is just in my organization, I think we're just having trouble finding vaccinators, period, to staff, not so much for the homebound population, but we have some mass vaccine clinic sites we set up where they're vaccinating 500 people in one day. And so just to find people to do that, my sense is they don't want to necessarily restrict who they're asking to do that. And looking for folks to reflect the community to be vaccinators may not be top of the priority list. It's just getting enough people to be vaccinators. I still think this is a very important point because I think if you can get vaccinators that that have ties to communities and may induce more trust, you're going to get hopefully more people to say yes to the shot.
Mm-hmm. And could that be just people who are part of a certain profession? For example, if you've got an EMT coming to your home, you know, an emergency medical person coming to your home,
Mhm.
is that a trusted person? You know, or does it really need to be someone who is reflective of race and ethnicity? I mean, just, you know, I don't know.
It's an interesting question. I don't know the answer to that. I guess it really depends on, I mean, you're right. There's some certain patients where the EMTs get to know that particular patient, that homebound patient who's falling a lot and pressing their lifeline button.
Mm-hmm.
So that's entirely possible. I'd be curious to see if anyone's ever studied that, whether or not people perceive the EMTs as being a familiar face, a trusted person.
Yeah.
Well, and I guess I'm wondering too, I think I heard in one discussion the idea that even if the person giving the vaccine, who obviously has to have a certain amount of training, certification, and so forth, even if that person isn't the trusted person or isn't the person who reflects the race and ethnicity of the community, maybe there's someone who's accompanying them. Maybe there's, you know, sort of an ambassador, right, who's traveling with them into homes because that helps members of the community feel, okay, well, if this person trusts them, then, you know, that gives me extra confidence. Maybe that's the, you know, the best we can do in situations where there's such a limited pool of actual vaccinators.
Yeah, this is Jennifer. I think in terms of the trust, I think that conversation was more around trying to help folks in some of the rural communities in Oregon get over the hump of not wanting to get a vaccine. So being influenced by peers and people they trust about why it's important, why they should, and then also, you know, how to get one and getting help there. But I feel like I read in some article, and maybe it was the Kaiser one, about you know, either the EMTs or the fire department being a trusted group, because they're often, and especially I think in rural areas, the people who are homebound that have regular needs, that's who they're calling. They're calling the ambulance or the fire department, so they actually have relationship and know. Maybe it was then the Seattle, the King County project, that's where they were talking about that big connection with the fire department, because they sort of know the homebound population because they visit them often.
I think that would make sense in a rural area, right? Or if there's a volunteer fire department or something.
Yeah.
Because there's that connection. We do know that if people have a doctor with a relationship and they trust that doctor, they're much more likely to listen to the advice to get vaccinated. And so I don't know that it matters as much who's, even if the doctor is not the one giving the vaccination, that people are more likely to accept a vaccination. Which is why access to primary care is so important, right? In a moment like this, because if people have that relationship, they're more likely to be vaccinated.
So
Yeah.
I'm going to ask that we go to our last slide as our time is about to run out. Thank you for the wonderful information and conversation today. We will be sharing the slides and the recording following the event. TIFO will continue to host these 30-minute huddle calls on Wednesdays and Fridays on topics related to enhancing access to the COVID-19 vaccines for people who need them administered at home. And our next call is on Wednesday, April 14th. Our featured speaker will be Edwin Walker, Deputy Secretary for Aging at the Administration for Community Living. And we hope you will join us and spread the word about this series. I am, as usual, pasting the link to register for all the April Huddle calls in the chat. I want to thank you all for all that you are doing and have a wonderful weekend.
Thanks everyone.
Thank you.
Margie.
Bye-bye.